Good morning. Sorry about that. I'm a little late. I apologize. How's everybody doing? I'll give people a couple minutes to kind of stream in. Again, I'm sorry. I'm a minute or two late. I apologize for that. Good morning. Good morning. Good morning, Mika. How are you? Happy holidays. Thanks for joining. I appreciate you. No sound. Thank you. Let's see. How do I get that up? Is that better? Can you hear me better? Good morning. Can I get a thumbs up or an emoji if folks can hear me? I got a notification that my sound was off. Are folks able to hear me? Let me know if you can hear me. Oh, perfect. Okay, good. Awesome. Thank you for that. Good morning. Good morning. All right. Sounds good, Mika. Thank you. How's everybody doing? I just wanted to check in. Maybe I'll give a couple minutes for folks to stream in. I was even late, so I apologize. I'll maybe wait a minute or two. And then we'll kind of check in and we'll get started. I hope everybody had a great holiday. Yeah, how are people doing today? It's nice out. It's not raining. When I walk the dog, I was like, yes, there's no rain today. We took a little bit of a longer walk, which is always nice. He appreciates that. Oh, fantastic. Good. Welcome back, Mika. All right, great. Okay. Yes. Lovely. Happy. Yes. Happy day. So it's the holidays. I hope everybody had a fantastic holiday together. I also want to just take a minute and acknowledge that this time of year can be tough for some folks. So I just want to hold space for that because the holidays can be hard for a lot of people. I know for sure people have suffered loss in families or struggling with health issues, families can't get to them. I just want to acknowledge that and recognize that it can be a great and joyous time, but for some it can be a really, really tough time. So wherever you are on that spectrum, my heart goes out to you. If you're having a fantastic holiday and it's all cheer, that's fantastic, and count the blessings, and I love it. And for those that are struggling during the holiday season, I also just want to hold space for that. So I'd love to know how folks are doing. Thumbs up, thumbs down. How's the holiday? Just give me a little bit of feedback, and then we'll kind of get into things this morning. I'd just love to know how folks are doing out there. I see a happy one, so I love that. Quick emoji or something. All right, great. Okay. So, love it. Peaceful. Oh gosh, that sounds amazing. Isn't there just something about like just peace, like feeling like a calm? It's interesting. One of those things that I've noticed during this whole menopausal transition is I have a very, it's something about like my nervous system, right? I have a very low tolerance in my nervous system for a lot of stimulation. So I find myself needing to find quiet more than I feel like I did in my younger years. So that notion of peace really speaks to me, right? Like just being at peace and finding that quiet space. So thank you for that, Mika. Yeah. So I want to ask, Melody, are you on? I know New Horizons is here. Melody, is that you? Just give me a thumbs up if that's you, or if that's, the reason I'm asking is, so, Melody is an occupational therapist and deals a lot with, yes. Okay. Awesome. Deals a lot with sort of, and maybe Melody chime in if I'm getting this wrong, but, sort of sensory adaptation or sensory input, which we see change during menopause, right? So I may ask you to be a resource at some point, Melody, because I think it's an interesting topic when we talk about menopause. There's so many symptoms that happen, and they're sort of the typical, and they're for sure. Everyone knows about hot flashes. Everybody knows about night sweats. They know about the sleep disturbance, the weight gain. I think most people know about that. And then there's these other subtle things, like some oral stuff that can happen, like really like sensitivity with food and like burning mouth and those sorts of things. So I think there's some interesting sort of more subtle symptoms. Sensory processing. Yes, that change is related to hormones. So Melody's awesome with that stuff. She's part of New Horizons. They are in Tigert, I believe. Correct me if I'm wrong, Melody. So maybe we'll touch on that. Maybe we'll do a separate thing just talking about all that sensory processing, because I think that's a super interesting concept. And again, my whole like input tolerance has changed significantly. So sorry, I digressed a little bit, but I just wanted to touch on that. So for those that are joining in, we just sort of held a little bit of space for the holidays. Hopefully folks had a peaceful one, happy one, but to just acknowledge that the holidays can be hard, especially if folks have lost loved ones. My cousin actually posted, so my mom, I've lost my mom, my grandmother, and my sister. So he posted this about how holidays just aren't the same, right? I've got my kids, I've got my family. I love my family dearly, and it is special. But when you don't have those people with you, the holidays can be hard. So I hold space for those people too. Yeah, awesome. So Melodies, yes, they are in Tigert, and maybe we'll do a little live together, maybe about some sensory stuff related to menopause. Okay, so today what I wanted to try to tackle was, how do you have this conversation with your doc, right? How do you get prepared for that visit? What do you ask? Thank you. Peace to you too. Thank you, El Lovely. So how do you prepare for that? What do you ask? What information do you go in with? And how to navigate all of that, right? So I wanted to try to just give my thoughts and have a conversation around that. And if folks have navigated this already, and if they have a great menopause provider, physician that they have, share that, please. Because some of this is just sharing resources with each other. So if you have somebody that you love, please share that with the group, because that's part of it too, is a referral is just as good as anything. Excuse me. So I think the first thing is finding the right physician. And there's resources out there. So the National American Menopause Society, NAMS, is an organization, NAMSA, that physicians can get certified. I know for sure physicians, I suspect nurse practitioners can as well, but I know for sure physicians. And I have a little bit of a bias. I don't mean to exclude, APPs or other providers. But as we've talked about with menopause, there are other really important things to rule out, to make sure we're not just saying everything is menopause, and to also make sure that we are optimizing people's health, because there's some significant risk as we go through menopause and as our estrogen declines. And I want to make sure that people have the best individual to manage all of that. Now, there's some really excellent physicians and there's not so excellent physicians. So just being a physician doesn't mean that gives you, like, woohoo, you're the best. But I just want to make sure that people have the right person that has the depth of knowledge to make sure we're ruling out things and to make sure we're optimizing people's health, whoever that may be. Let's see. So awesome. So Mika's saying she has a nutritionist. Oh, that's fantastic. Hormonal balance. That is amazing. And I tell you, nutrition is so wildly important. And I don't know, we touched on it a little bit with when we talked about sleep, and we talked about hot flashes and night sweats. Optimizing our nutrition for hormonal health is so important. And maybe Mika, I will get her information, and maybe we can do a live together too, for the group, just to start to bring together these people that are in this space, because it takes a team. I honestly believe it takes a team. So maybe we can all connect and do that. We'll have one with Melody, and then I'll do another one with that nutritionist, or maybe we get everybody. I don't know. Maybe we do it all. We'll see. So finding the right doc, right? Are they NAMSA certified? And I'll say this also. as a physician, going through medical school, going through residency, going through my fellowship, doing more board certification, menopause treatment and symptom, like the treatment of it has not been covered. Even in traditional kind of standard OBGYN practice or family medicine training or OBGYN training, that's not part of our typical training. And to be honest with you, nutrition is not either. So this is stuff that the physician takes an interest in after they've gotten their board certification. Says, you know what, I raise my hand, I want to do more. And they go back and they study more and they get certified to treat menopause. So NAMS is an organization that does that certification. They do you take a test and they give you the stamp, boom, you're NAMS certified. So at least from that standpoint, you could say if a provider or physician is NAMSA certified, they've gone through that educational process to be certified. There are some folks that have been treating menopause that may not be NAMSA certified, but they may be qualified, right? So I don't want to say that everyone has to be NAMSA certified, but at least if they are, they've reached kind of that bar, that level of understanding. I am not currently NAMSA certified. That's in 2025. So again, a lot of what I do as a physician is, what are my patients looking for? What am I going through? And this whole menopausal transition has really come to light. Okay, I need to learn more and do more because I want to be able to help my patients more. So that's on my list for 2025 to get NAMSA certified. But acquiring the knowledge can happen in advance of that. So that's one thing, is saying, okay, who I'm seeing, are they NAMSA certified? So that gives you a certain level of comfort that they have that that knowledge. Then the next thing is insurance. Does insurance cover said provider? And insurance is a whole nother can of worms. I won't get too much into the nuances, but obviously, you check the list, you call your provider, the number, and say, ooh, is this individual covered under my insurance? That's one way. The other way is you do direct pay, right? There are docs like myself who have a private practice where I work for and with my patient, and there's no insurance or middleman in between our therapeutic relationship. So when we are unwinding disease and acquiring health and putting in plans and ordering labs, it is just the two of us deciding what to do. And I've worked hard to get costs significantly reduced so that things sometimes end up being cheaper going direct, paying for labs direct, than they are running it through your insurance. And you don't have to worry about, oh my gosh, is that covered? And then finding out it's not covered after you've done the labs and you get this whopping bill. So going direct, right, is another option. I know there's some online menopause care being provided. Whether or not they're insurance or not, I don't know. So there's options around that. I would argue that having an in-person visit is the best, because again, it's about putting eyes on somebody, having a history, developing that relationship, doing an exam, and then deciding what do we need to rule out before we roll into, okay, this is menopause, and then making sure that we're taking things, taking care of things on the back end, as opposed to, just here's your hormone therapy or your non-hormonal therapy medication. You want to try to make this as coordinated as possible. Now, if you are unable to have your primary care and your menopause care with the same individual, then sometimes you have to split that. And that's where you start looking for just someone to do menopause. Insurance versus direct pay. Then what I would recommend is people do a symptom score. So I posted this on my page a couple minutes ago. You can find that online, and you just take the score, the scale, right? 0 is you don't have it, 1 mild, 2 moderate, 3 severe, and you get a total. Anything above 15 correlates with estrogen deficiency. And I would take that with you to that visit and say, okay, these are the symptoms. These are the ones that are most severe. Come in with sort of your plan ahead of time. Keeping a journal of your symptoms would be super, super helpful as well. Coming in knowing your family history, right? Do you have underlying heart disease, early heart disease in your family? Early is considered women before their 50s, men before their 60s, having heart problems or heart attacks. that is early heart disease. So that provider, menopause or otherwise, needs to be really keen on managing your cardiovascular health. Do you have history of cancers in your family? Breast cancer? Making sure that, again, we're optimizing your health, because we know these things are going to increase as our estrogen declines, right? We know we're going to have an increased risk of things. Osteoporosis, was there early osteoporosis in your family? As a sports doc, I would see a lot of, we used to call it female athlete triad. Now it's called relative energy deficiency syndrome, red S, because it happens in males as well, where much younger, we are burning through calories more than we are consuming, and girls weren't getting their period was the first indication, but then that led to osteoporosis or osteopenia, or really multiple fractures is what we would see in the younger years. And then they would end up with like osteoporosis like in their 30s or 40s, right? So understanding some of that history, if I'm taking care of someone and I knew they were a heavy competitive athlete younger, I may screen them for osteoporosis much earlier than insurance says we should, right? And again, I'm direct pay, so I can do those things. Sometimes in insurance, you can write the note and justify, and we all cross our fingers and hope that someone, behind a desk says, oh, we agree with you, doctor, you should get that test. But those are some of the things you need somebody to pay attention to, and make sure you're screening for and ruling those things out. So osteoporosis. And then the other thing is metabolic disease. Again, we know as our estrogen decline, our insulin sort of sensitivity worsens, or we develop insulin resistance, which gives us an increased risk of developing prediabetes or type 2 diabetes. So if I know someone's coming to me and has a pretty deep family history of diabetes, and then again, I'm assessing their lifestyle, I can already see, okay, we're kind of at an increased risk, in addition to some labs that I would recommend. So we really want to get in front of that and manage your metabolic health throughout menopause so that we don't see any sort of health consequences on the back end, right? So really making sure we're managing you in totality is super, super important. So make sure you're finding the person that can do that for you. And then I would come with an understanding of, what are your preferences? So we know there's hormonal treatment, estrogen, progesterone, there's testosterone, progesterone, there's testosterone as well. We know there's non-hormonal medications out there. We know for sure lifestyle matters, and I say lifestyle, and that's nutrition. Mika brought up a great point, right? Working with a nutritionist, really optimizing our food intake is profound. So maximizing your nutrition. Are we exercising? What are we doing to really help our metabolic health? There is this general guideline of 150 minutes a week, right? Moderate intensity. As we get into menopause and this menopausal transition, we have to think about our exercise a little bit different. We have to work in, we don't have to, I apologize. The recommendation is to work in strength training. That is profoundly important for us. So lifting is huge. And even for me, I've been sort of athletic my whole life. Lifting, I love, but I don't know it well. So it's something I'm working into, but lifting becomes really important on top of maintaining sort of this fitness base that I think is that general recommendation of 150 minutes. So lifestyle includes exercise, sleep we talked about already, right? Really maximizing our sleep, doing your sleep clock. So come into that appointment understanding what's your tolerance for things. Are you ready to change your lifestyle? Are you ready to change your nutrition? Do you want that to be really one of your treatment modalities, which I would argue it really has to be? Medication's only going to take us so far. And then, are you comfortable using hormonal treatment? Are you comfortable using non-hormonal treatment? Do you want a medication or do you really want just lifestyle? So come in knowing all of those things as well. Then that's kind of like the pre-planning, right? What you can do before you get there. The other thing I would say is I would, for those that are early in the stage, think of doing a visit before you really get into the throes of it if you can. Similarly in healthcare, we have kind of pre-pregnancy visits, right? Preconception, people are thinking about getting pregnant. and they go to their doc and they start talking about it. Oh, are you taking folic acid? We do we do all the labs ahead of time. We should treat menopause like this. You should have a visit outside of your annual visit, right? So your annual visit is different, right? Then you need a problem-based visit. And this is insurance craziness, unfortunately. Your annual insurance, some insurance will quote unquote cover that. That's separate. That's like wellness, that's lifestyle. And then you want a problem-based visit for menopause, and you should schedule that ahead of time to say, hey doc, I want to come in and talk to you about menopause. So one, the doc knows that that's what you want to come in and talk about. And if they are not certified, I hope they raise their hand and say, hey, you know what? I'm not the right person for this. Let's find you the right person. Or if they are the right person, they're prepared. So you almost want to schedule that visit in advance, come in knowing that's going to be the conversation, and you come with your information. You come with your symptom score. You come with your family history, if this is different than your primary doc. You come with what are your preferences for treatment. All of that, your journal, whatever you've been keeping, you come say, okay, boom, this is what we got. Because the more you come with, the sort of further along you can be with that visit. The other thing I would say, if you can get an early morning visit and come to it fasting. Some of the labs that I would typically recommend for this would be fasting labs. So if you can already be fasted at least 8 hours, you can have water, no coffee, or food, or you can have coffee, just don't put like creamer and all that stuff in it. Then you can have those labs potentially done or drawn that day. So come fasted with that visit. Again, problem-based visit, because for insurance, we hope we can get things covered for you if it's problem-based as opposed to, good morning, Miss Lori just joined us. So if it's problem-based, hopefully insurance is going to cover that, as opposed to it being built into your annual. They will not cover it if it's under your annual visit. So make sure it's a separate visit. So that's the first thing. Then when you come in for this, there should be some, good morning, there should be some, good morning, how are you? Standard labs. So the basic labs that we run, CBC, or complete blood count, that looks at your white blood cells, your red blood cells, distribution of your white cells. That can rule out infection. It can rule out certain cancers. It can rule out anemia. When we talk about, are there other things going on that could be causing some of your symptoms? Anemia could be one of them, right? That fatigue and all of that. We want to make sure someone's not anemic. So CBC. The next thing is called a comprehensive metabolic panel, or a CMP. That looks at your kidney function, your liver function, looks at your electrolytes. A little bit about liver function. In traditional healthcare, the lab values that we look at for liver function, most docs will say, as long as you're in the normal, you're fine. For me, again, lifestyle, and because metabolic health is so wildly important, I look a lot at people's liver function test, and I'm looking to see, not just are you in the normal, but are you trending on the upper end of things? Because if you are, then I can already see that you're developing some metabolic dysfunction. The reason is your body starts to deposit fat in your liver. There's something called non-alcoholic fatty liver disease, NAFLD. It's probably the most common liver disease right now. It's not because of alcohol, but it's non-alcoholic. It's a metabolic syndrome where the liver is being replaced with fat. So that is an early indicator of metabolic disease or metabolic dysfunction when your liver function tests start to climb. So even for you, right, when you get your labs, even if it's normal, start looking at, okay, where was I a year ago or 2 years ago? Am I trending up? If it's normal, okay, but am I trending up? If you are developing metabolic dysfunction, and I would hop on that. That should be like red flag. Start working on changing lifestyle, exercise. Are you drinking alcohol? Whatever the case is, to start unwinding your metabolic dysfunction. Because again, as you go into this menopausal transition and your estrogen declines, you are already at an increased risk. So the best thing we can do is stack the deck as early as possible, so we go into this as fit and as healthy as possible. because there's going to be sort of an uphill, you know what I mean? There's going to be a bit of a decline anyway. So electrolytes, kidney function, liver function, we'll get with a comprehensive metabolic panel. Then there's kind of other additional, and then a cholesterol panel, sorry. They'll usually order a cholesterol panel, and that's to look at heart disease. And maybe what I'll do is a separate video outside of this live to really talk about cholesterol panel, because I think we're doing folks a disservice. We're not helping them understand it enough to really treat early enough. And I'm not saying treatment is with a statin, because again, I'm all about lifestyle. And we can unwind some of this with lifestyle, if not most of it with lifestyle, unless there's truly a genetic hypercholesterolemia. So maybe I'll do that separate, because I don't know if it's in the, I think it'd be tough to do that today. I think it'll just take too long. But so cholesterol, just super quick. Oh, awesome. Okay, I've got a thumbs up for the cholesterol discussion. Love it. All right, so boom, done. It'll happen then. I love to talk about it, but it's always like, just because I love it, I don't know if everybody else wants to hear it. So thank you, Mika, for that confirmation. So cholesterol, there is HDL, we'll start there. So high density lipoprotein. Most people say, ooh, that's the good cholesterol. Then there's LDL. Yes, and how we determine genetics. I love that. Yes. So we'll talk about that cholesterol, and then how we decide if it's familial. Oh my goodness, I'm sending off emojis. If it's familial hypercholesterolemia. So I'll address both of those in that separate cholesterol talk. So HDL, high density lipoprotein, and then LDL, low density lipoprotein. Those two are, we call HDL, people usually say is good cholesterol, LDL is bad cholesterol, and that's not quite right. What we're talking about with those two is the protein to cholesterol ratio, and how those two particles are able to move through your vascular system, through your blood vessel, and through the wall of your blood vessel. So HDL is able to kind of, as it's moving, if you think of the lumen, right, a vessel is circular, and then the wall itself, right, of the vessel. So HDL is able to move in and out of that vascular wall. So it's got this super cool property where if it's scooching through, it's running through the serum of your blood, it can go into the wall and come out of the wall. So it can carry things in and out and deposit it someplace else. LDL, on the other hand, is sticky. It's kind of tacky. So it goes into the wall and it gets stuck there and it stays there. So that's how we get plaque eventually, right? Those things start to collect and accumulate because of LDL particles. So yes, we want more high density lipoprotein, and we want more or less low density lipoprotein. So L, you want low, H, you want high. But they're not really good or bad. It's just how well they can move and the disease that they can cause, or the downstream effects they can cause. So LDL is more harmful because again, it's sticky. It kind of gets stuck, and then it kind of recruits its friends to get stuck with it, and that's what ends up being a plaque. And then you have total cholesterol. Again, in traditional healthcare, we treat the total cholesterol. It's kind of like this nebulous number. We say, ooh, under 200 is where we want people to be, but to me, it's about the LDL, it's about the HDL, and it's about your triglycerides. And looking at your HDL to triglycerides ratio is an indication, again, of metabolic health. Metabolic dysfunction is the root cause of, I would say, probably 80% of what we treat in healthcare. So making sure your metabolic health is like dialed in is like bar none the most important thing. So that HDL to triglyceride ratio, I would start looking at that, right? That's important to know. And then protecting their brain. Okay, I'll table that. All right, but so because I've got a question about higher cholesterol levels because it's protecting their brain. Okay, we will talk about that. Ooh, I would love, yes. Help me remember that, Mika, because I have a lot to say about that. Okay, awesome. So the question is really around, should we have higher cholesterol levels because it's protective to our brain as we go through as we go through menopause because our estrogen is declining. So yeah, I'll wrap that in because vascular health is profound for brain health. So yes, I will definitely talk about that. So HDL to triglyceride ratio, where is your LDL? And then where is your HDL? Those to me are the three most important things. Total, again, it's kind of nebulous. So those are the three that I think you should start looking at. So look at your labs. Like after this visit, if you can, go on your my chart or whatever, look at your last 2-3 lipid panels. What are your numbers doing? Are they normal? And if they are they trending up? Where's your HDL? Where's your LDL? What's your family history? Those sorts of things, and start to consume it like that, as opposed to, oh, it's normal. Where are you trending? Where are you headed? Because where you are today, based on your lifestyle, is going to be very different. If we keep going where we are 5-10 years from now, that's going to be a different story, right? Okay. Then I would say there's other. So here are the others that I think we should start doing. And I can't promise you that insurance is going to cover all of this. And this is where it gets really unfortunate, because I think we could be doing more to keep people healthy, but insurance gets to decide if that's okay to a certain extent, right? And that's why going direct can be helpful. So the other thing I draw on my patients is something called lipoprotein A, LP little a. That is a genetic marker. That's your genes, right? And we know now that lipoprotein A is the thing that puts us at risk for developing clots or atherosclerosis or plaques in our artery. So I check lipoprotein A. There's some medications that are coming up now that'll work at lipoprotein A. But for me, it's about, if I see somebody has a high lipoprotein A, they've got some family history, we are going to double down on all lifestyle. We're going to double down on, maybe we talk about medication. Like, we are going to be aggressive because they have a genetic predilection for having atherosclerosis, heart disease, right? Stroke, heart attack, all the things. And then again, as your estrogen declines, your risk goes up. So we gotta dial in big time. So lipoprotein A. The other one is ApoB. That is, it's a protein that carries kind of cholesterol around. So as opposed to just looking at your LDL, you want to look at your ApoB, because again, it's about that cholesterol moving through the system, because that's the stuff that's going to get sticky and tacky and hit that lining of the vessel and cause plaque. So looking at ApoB, it's a finite number. You want to look at that. So that's a test that you should be getting as well. I also recommend people get high sensitivity CRP. It's an inflammatory marker. It's more specific for heart disease though. So some people may know about CRP and ESR as it relates to like a rheumatologic disease or etiology. So high sensitivity CRP, little h, little s, CRP is for cardiac, for heart health. So that's another one that I recommend people ask for and screen for. So again, to that point, you need to make sure you're seeing somebody who knows what to do with that, which is a whole other can of worms, right? So when you're sort of interviewing people, and there's nothing wrong with that. I think in healthcare, as consumers of it, we just sort of feel like, oh, we get who we get. No, you can look around, shop around. If you have to do insurance, make sure people are covered if you want. But shop around, make sure it's a good connection, it's a good fit. Make sure that they're going to be able to give you what you need. So knowing somebody or seeing somebody who understands some of this stuff and knows what they're looking for. Then there's hemoglobin A1C. Most people know what that is. That is, so in your CMP, you'll get, good morning, Sandra. In your CMP, you'll get your fasting glucose. That's kind of your first little blip of, how high is your glucose when you wake up and you haven't eaten for an X amount of time. That again is a marker for insulin sensitivity. How well is insulin working to move sugar out of your bloodstream and, into fat, into liver, brain, wherever it needs to go, muscle. So if your fasting sugar is high, then we follow with the hemoglobin A1C. Hemoglobin A1C. So this is so I'm being asked, will insurance cover these as part of the annual? It depends on how. So they probably will not cover. One, I can't guarantee it. So I don't know. But those would be questions that you talk to your primary about. if, let's say, you have early heart disease in your family, right? So your mom passed away of a heart attack at like 49, or your dad or someone in your family passed away super early, then potentially you could get a lipoprotein A and an ApoB as part of your annual visit, potentially, right? When they're doing your lipid panel. So they do your cholesterol panel, they do a lipoprotein A, and they do an ApoB. Maybe they can do a high sensitivity CRP as well. So I would talk to them about that as part of your annual, if you have early heart disease, and they may be able, if they have that in their history, then they can hopefully tie that in and hopefully insurance can cover. The maddening thing with insurance is, even if your doc does all of that, there's no way to know what insurance is going to do. So they can order that, and they won't know, you won't know until the lab is done, and then you get a bill on the back end. And then you're kind of stuck because you've already run it through insurance. And this is where things are so frustrating with insurance. So I don't know. And I don't know that you could try to call your insurance and see, but I don't know that they would tell you one way or the other. And this is part of why, again, I do direct primary care, right? I can do this, and these labs are not expensive. I can tell you the cash price to the penny. I don't have my sheet in front of me, but these are not expensive labs, right? Lipoprotein A, I might shoot myself in the foot, but I think it's $5. I mean, these things are cheap. But insurance isn't healthcare. I'm sorry. I wish I had a better answer. So I would do some digging and ask some questions first. So let me see. Insulin is another great topic. Yes, that's a good one. So I'm getting another insulin sensitivity as another potential topic, because for sure that changes as we go through this menopausal transition, right? As we start to lose some of our, lose that estrogen, we definitely are at increased risk for metabolic dysfunction, type 2 diabetes. So yes, okay, for sure. Even in the context of no history of diabetes. Awesome, love that. Yeah, so another one, right? Get some labs done, and someone wanted specifically a selenium, and doc said it wasn't covered and would be around $200 or more. And that's if you run it through insurance, right? So you can get direct labs. I believe patients can actually order their own labs. I heard this. I can't confirm it for you. It may not be at the rate that I get, the wholesale cash rate that I get, but man, I would imagine it's cheaper than running things through insurance. So we can run a little, oh, okay, that's great. Yeah, if your nutritionist can order the labs, that's fantastic. That's great. Fantastic. So there's ways to get around there are ways to do this. So it sounds like we got some good resources in this group. So we'll have to share some. We'll get her on a live together, because it sounds like she can do some good things for people. Okay. So where was I? Lipoprotein A, ApoB, high sensitivity CRP. Oh, we're talking about fasting glucose and then hemoglobin A1C. So if your fasting glucose is high, above 100, again, is the marker, then we say, we should check a hemoglobin A1C. Hemoglobin A1C is another way that we can diagnose pre-diabetes and then type 2 diabetes. So if you're 5, yeah, I'd be happy to see you for sure. If you're 5.7, I think, to like 6.3 or 6.2, that's pre-diabetes. Like 6.4, 6.5 and above, that's type 2 diabetes. What I would say we should be doing is, because there are a lot of times that, again, I'm watching liver function. I see it trending, right? Fasting glucose is trending up. It's like high 90s, but it's not quite 100. A1C is 5.5. So they don't have a diagnosis yet, right? Insurance is very diagnosis driven. You have to have the disease before we can start to do anything, right? So I can't, in the context of insurance, they are not type 2 diabetic. So I can't really put that on the problem list. So we can't really bill anything for it, right? But I can tell that they are trending in that direction. So for me, what I'm starting to look at again in my private practice is something called fasting insulin. So again, it's about how much insulin is your pancreas pumping out to try to shuttle all that glucose in places. That's going to be high earlier than hemoglobin A1C, earlier than fasting glucose. So I'm starting to use fasting insulin in my practice because, again, I want to find metabolic disease as soon as possible to start unwinding some of this stuff, because our lipids can look normal, our liver function can look normal, our fasting glucose can be normal, but if our fasting insulin is high, the train has left the station, and now we got to try to reel it back. So that's one thing that I would, and again, insurance coverage, I don't know. Those are things you gotta talk about. All right. Then there's vitamin D, right? We're talking, I appreciate the two of you. There's vitamin D, again, fatigue, right? Mood disorder, again, making sure we're not missing something else. Vitamin D also is important for bone health as again, menopausal transition. Taking vitamin D with K2 is important for bone health. So making sure that that's been checked. Good morning, we got some folks. Sorry, somebody's giving a reminder to go take their vitamin D. So vitamin D and K2 is important, right? So do that. Then checking your magnesium. Good morning, how are we? Then checking your magnesium. And then if you're choosing to abstain from like meat protein, your vitamin B12, making sure that that's in line. Both of those are super important for cellular health, brain health, those sorts of things. So those are really important labs to check on. And then checking an iron panel is another big one. Again, anemia, fatigue, right? Making sure we can have a low ferritin. Our stores can be low, although we're not quite anemic. So that's the other thing, right? We do a CBC, your hemoglobin and hematocrit are normal, so you're not anemic, but you could be iron deficient, or your stores of iron could be low, so you don't have the building blocks to make the thing to make the hemoglobin. So again, checking a few steps early is important, so getting an iron panel is important. The other thing, good morning, how we doing? We got a few more people. You guys make me, I love it. Hopefully this is helpful. So please spread the word if it is. Let people know, because if this is helpful, that's my goal, is to just kind of be of service, because I don't think this information's out there. And it shouldn't be a secret, right? These are things that people should have easy access to. So please share with other folks. Good morning. How are we? Okay, so checking your iron panel. The other thing I wanted to touch on was thyroid. So again, traditional healthcare, usually they'll check just a thyroid stimulating hormone. And even that, again, the doc has to say, okay, I suspect, make the case, blah, 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 in the note, on and on and on. And then they check just a TSH, thyroid stimulating hormone. If that is normal, that's all the lab does. If it's abnormal, then it reflexes to what's called your T4 to see, do you have hypothyroid? Now, I will tell you that T4 gets converted to T3, which is the active hormone. That happens in your gut. So let's come back to lifestyle. Let's come back to nutrition. It's wildly important what we eat, because that creates gut health. Gut health is like a gold mine. So that conversion predominantly happens in your gut. So again, you can have TSH is normal, traditional healthcare, done. If it's abnormal, you get a T4, then they give you medication. Well, are you converting that appropriately? So for me, I order the complete panel, right? I look at TSH, I look at T4, I look at T3. Sometimes I'll even look at antibodies, thyroid antibodies, right? Separate. I get all of it because I really want to know, again, if you don't, I'm checking way back here. I'm not waiting for things to be diagnostic here. I'm checking way back here. And how can I support people so that we never get to that disease point? How can we start to educate people about their gut health, their sleep, the everything, to support them in health? So that's another one, getting your full thyroid panel. That's going to be a tough sell in insurance. But that's something to think about. So those would be the additional labs, right, that I would say to look at. Oh, good. Perfect. I'm glad. Yeah. So, and that's the thing, when you're in the right spot and you got the right person taking care of you, you're like, boom, yeah, I got that. I got it. That's awesome. That's what I want for everybody. I want everybody to have this kind of access and have an understanding so that they can go to their doc and say, hey, this is what I want, right? This is the information that you should have access to. And the challenge, though, it's not necessarily that your doc are the ones with the limitation. It's whether insurance is going to cover it. And that is, oh man, that's a tough one. And even if your doc does as best they can to build the case, they don't know if insurance is going to cover it, and then you're going to get stuck with a bill. And unfortunately, the only person you have contact with is your doc, and you're going to come back and say, well, why isn't that covered? And then our hands are tied because we don't have that information. We don't know that going in. We can guess based on past experience. That's why I say, again, vitamin D, usually insurance isn't going to cover that. We got to write a bunch of stuff in our note and do a bunch of things to say vitamin D should be checked. A full thyroid panel, not going to get covered. They'll cover the TSH with reflex. It's called. Fasting insulin, highly doubt it, right? Conventional medicine is you check their glucose and then you check an A1C if the glucose is above 100. Under 100, again, they probably won't cover an A1C. And then again, those extra lipid levels, that lipoprotein A, ApoB, high sensitivity CRP, that's a plus or minus as to whether or not they're going to cover that. So those are the things that I would say to get done in the visit. And maybe I'll go back. I apologize. Let's go back. So you look in NAMSA, you find a few providers. Okay, you check your insurance. Boom. Okay, you got maybe one or two people. You can set up an appointment, or I even have people come, at least in health, when I was in traditional, kind of a meet and greet kind of visit, right? Just to see, check the temperature, check the water, right? Is this a good fit? And then in that visit, you're asking, hey, are you comfortable treating menopause? Have you treated other patients that are like me? What are some, tips, or what's been your experience? Are you comfortable using non-hormonal or comfortable using lifestyle if that's your strategy, right? If your strategy is you really want to maximize your lifestyle, then you want to make sure you're with somebody that knows how to do that. So how comfortable is this physician at doing lifestyle? How do they have resources to a nutritionist that can support you, right? Because I know a lot about lifestyle, but I would still want to have a really good nutritionist that I can link arms with and say, okay, I've done the education, I've done the labs, this is what I know I want to unwind, and I can give you some general parameters for your nutrition, but then I would love to have a nutritionist that I can say, okay, can you take this the last 10 yards for me, right? Really help them come up with a good nutrition plan, meal planning, that sort of stuff. So having that to support patients would be really important for me, because I can't necessarily do all of that in my visit. But knowing that that's what they need to do and just having good partners. I totally lost my thought. Where was I? Are they comfortable managing lifestyle if that's going to be your choice? And then are there side effects? Are they comfortable talking about, hormone therapy if that's going to be your choice? What are the side effects? How do we manage side effects? And then again, my big thing is how dialed in are they for treating overall metabolic health and disease prevention, right? That's my big thing, because I think Black health is already we're not on the table half the time, right? And I think it's important for us, for me at least, to start having that conversation about how do we really get people healthy? I want to unwind disease if it's there, and if it's not there, let's prevent it, because our rate of death and morbidity and mortality is way too high. And if we have the right information and the right support, I have to believe that we can move the needle and create some generational health. Because if we start with us, then it trickles down, right? And we just continue to push that information down. Early intervention, prevention, as opposed to just managing disease month after month after month, and we're just waiting for what we know is going to happen. We know this stuff is going to happen. So let's unwind it or prevent it when we can. So those are my general tips. Again, the big thing is finding the right person, whether they're NAMSA certified or not. And again, full disclosure, I'm not currently NAMSA certified, but that's on my list for 2025. In addition to just taking really good care of people in my private practice. And for those that don't know me, I have a private practice, and I see patients direct. I take out the middleman. It's just me and my patients unwinding disease, creating health for them and for their families. We talk about health vision, right? What do you want for your health? And how do we get you there? That's what I do in my private practice. It's called Cerevive Direct Health. It's right here in Portland. So if anybody has specific questions about the topic today, shoot them towards me. I'm going to write a note about, we're going to do a lipid talk. So lipids, and then insulin. So insulin sensitivity was a separate one. Lipids, and we want to talk about genetics. Alrighty. Yes, you're right. You're right. It's generational wealth, right? Health is wealth. Oh my gosh, that's a whole nother thing that I would love to talk about. Oh my gosh. Someone find me like a financial advisor or whoever, and I want to have a conversation with them because we talk a lot about saving money, financial health and generational wealth. Well, if you don't have your health, the bulk of your savings that you put away are going to be to pay for chronic disease. So to me, the two are like intimate related. We have to be healthy. Otherwise, all we're doing is saving money to pay for sickness. So yeah, that's a whole, oh my gosh. Why y'all get me all fired up today? I love it. Yes, I'm 1000% accepting new patients. Yes. So a couple ways to find me. If you go www.ceravitewellness.com, and then on that website, there's like a meet and greet. It's free. It's just you and I, we have a conversation, see if it's a good fit. So you can get to me that way. The office number is also 503-877-1186. So be happy to chat with anyone. Oh, I appreciate you. Thank you, Miss Lori. I appreciate you. Yeah, so accepting new patients, be happy with chat with folks. Any questions about today? Anything else? Okay. So I'll see everybody next week, 10 o'clock. Can I put that in the chat? Oh, yes. Oh, all right. Let's see. Yes, let me do that. Let's see if I can do this. So there's the website address, and then this is the office number. The other thing that's different about me and my practice is I offer direct access. So one of the things that's huge for me in healthcare, traditional fee-for-service, insurance-based, the doc is like buried behind like 17 layers of people, right? You send a message on the portal to your doc, it goes to the nurse, and then the nurse sends it to the triage person, and it takes 4 days for your doc to actually get that message. When my patients, and they can text me, it's me on the other end of that phone. There's no nurse or anybody, it's me. Patients get direct access to me. We can triage together. I can answer quick questions. If you send me an email, it's coming to me. I'm the one answering the phone if I'm not in the middle of a patient visit. And it's important that I keep it that way because I really want people to know that I am their doctor and they have access to me. Obviously, if it's 2:00 in the morning and it's that urgent, that's probably an ER visit, or you send me a message and I'll respond the next day. But I mean, my goal is to really be accessible to people because that's what keeps people healthy. We spend an hour together, and if you leave and you're like, oh man, I forgot that question, you just send me a text and we take care of it. All right. Thank you, everybody. It has been a pleasure. I'll see everybody next week at 10 o'clock. We'll talk about, I'll start working on the cholesterol talk and the insulin talk, and we'll figure out how we squeeze that in. We'll do a separate live for that one. Okay? Thank you, everybody. Have a great day. Have a great holiday. Happy New Year. Let's create some health in 2025, shall we? Yes. Take care. Bye-bye.